Okay, this is a analysis of the exact system for precision clinical trial matching. CancerBot is a free patient-centric service for precision clinical trial matching. Exact is the underlying open source software that we are giving to foundations and many other stakeholders that want to do true precision clinical trial matching. So by way of introduction, other trial matchers, both commercial and open source, have historically ranked trials for suitability for the patient, and then they assess whether they work or not based upon whether a doctor labeled gold standard of the limited test set of trials is within the top 5 of the rankings from the trial matcher. Now, the problem with that is that it does not actually do true precision eligibility assessment. Is that patient truly eligible for the trial based on all the attributes? So let's just describe a little bit more how the exact system works. Over here, where you see original trial, that is a real trial, a real follicular lymphoma trial. It is NCT 0497-0901. You're going to have a hard time reading these eligibility criteria here. That is basically part of the problem. It's very difficult for patients to determine whether they're eligible or not. This is actually just a fraction of it. This would go on, and it's quite difficult for patients or clinicians to figure out whether you're eligible. So we have this exact software. Exact stands for Extraction of Attribute Criteria for Trials, exact. We have a trial loading ETL. ETL is extract, transfer, and load. And that works against multiple unstructured trials databases, clinicaltrials.gov, EUCTR, ISR-CTN. It then puts it into a trials data lake. Then we have a lot of deterministic, this extraction ETL here does a lot of extraction of structured criteria that we do not need a large language model to help us with. And then it puts those back into the trials data lake. When those trials then have that sort of first pass of extraction done, then we use our LLM-based extraction engine with several different LLMs actually, Gemini, GPT-5, and others, depending on, they all have their strengths in extracting various attributes. And then that goes and extracts the additional attributes and then deposits them into this master database that's a true structured database with all of the attributes of the 80. For example, for follicular lymphoma, there are 84 attributes used in trial eligibility criteria. Now, the other thing I want to highlight is that the way that this works, it's not sufficient to just take a trial and hand it to the LLM and say, give me back all these attributes. It will not work. So you need hand-tuned prompts for each of the attributes. So you do need, we have subject matter experts that use this tool called the Prompt Workbench to create prompts that live in a prompt database. We then have another component called the Technical Prompt Builder that enhances what the SMEs enter as the prompt. And then that's all fed to this LLM-based extraction engine. And then what it does, of course, is ask many questions, at least 84 questions per trial to get each attribute. And each of those 84 prompts for the different attributes has been hand-tuned to avoid hallucinations, to avoid false equivalencies, and so it then works with very high quality. And the prompt workbench lets them see the results of that against the trial they're testing with. The important thing is, however, those prompts are then hand-tuned and then they're executed against all trials. So they're executed against all 1,291 actively recruiting follicular lymphoma trials. The subject matter expert does not need to go and look at every trial. They just need to hand tune each prompt with a small set of test trials to get them perfect at extracting the information. And the result of this, once it's in the master database, is that for this same trial, on the right, you can see that we have a whole bunch of attributes, and the required is what we've extracted as the criteria. So things like it disallows certain pre-existing conditions. You have to be refractory. Certain stem cell transplant history was excluded. There was a washout range. There's a required tumor grade. And then other behavioral attributes. And then, of course, on the right is what a patient enters as their data, and then, of course, based upon what they've entered, it will determine whether or not they're eligible. So everything's green here. They are fully eligible for that trial. There's no other method of doing that, except reading through all of this yourself on the right, or having your doctor do it. It's extremely time consuming to do that against hundreds of trials, of course. Okay, so that's how the system works. Now, we've said this is an accuracy analysis. How good is this, right? It's a very hard problem. Does it really work? So what we want to do is assess the overall accuracy, the precision, how often the attributes are extracted correctly, the recall of the attributes that are in here in the wall of text here on the left. How many do we get? And then F1 is the harmonic mean of precision and recall. You always want to be tracking that, because you can optimize too much for precision, like your guesses are always correct, and then you won't have good recall. You won't find all the attributes. So F1 is our primary metric. Some people will refer to it as accuracy, but in this kind of a system, the right primary metric is F1, and it's a slightly different formula than accuracy, which is its own metric. But the way we're measuring accuracy is F1. Now, how are we going to do this? How are we going to measure accuracy? Are we going to have all the subject matter experts go through all 1,291 trials? We don't need to do that. What we want is something like over 80% confidence that we're within 5% of our estimates. So we chose 100 trials at random. That gives 81.5% confidence given our 0.81 F1. And then we have the subject matter experts go through all 100 trials and 84 attributes and mark what's there. It's quite an effort, even just doing that subset. It's like 8% of all the trials. Then you can see here's the results. So the overall results, so the recall is pretty good. It's 0.85, the precision is 0.78, and the F1 is 0.81. But let's look at the categories. You can see that for the numeric categories like labs, there's certain disease-specific attributes that are generally numeric labs, blood levels, hemoglobin, absolute neutrophil count, and then various behavioral attributes that are generally Boolean, like have you had a pregnancy test, do you smoke or not? And these are all well above 90% in precision and recall and F1. The laggard, of course, is treatment. Treatment is generally, the requirements of a trial will be things like had to have a proteasome inhibitor, or couldn't have had a corticosteroid, or had to have immunotherapy. The patients, of course, are not entering that into their record. They're entering a specific therapy. So we have to have this knowledge of therapies, like what are the therapies for the disease, the standard of care therapies for the disease, what are the components of those therapies, and what are the types. So an example is R-CHOP is a very common therapy for follicular lymphoma, and then that breaks down into various components. There's a corticosteroid, there's a proteasome inhibitor, there's an immunotherapy, and then those components have types. And we have all of that knowledge, so we're able to do that matching. But as we go and look at this unstructured text here as they describe therapies, ambiguities can arise. So at the time that we did this is just back in May, it's now November, we were only at 0.68 F1 for that. You can see the recall was lower. We missed a bunch of the criteria. The precision's not bad, 0.75. We missed a bunch of the criteria. System's significantly better than that now, but we're not going to keep moving the goalposts. This is what we measured at the time. Having these, of course, these accuracy metrics is part of how we decide what prompts to continue to work on in the prompt workbench. So this exercise is very useful, and it's all instrumented into the software. So as we can see that certain attributes in certain categories, or just specific attributes, we don't have, for example, good recall for, then the prompt engineers can then modify those prompts. That is the accuracy that we've achieved. As we mentioned, other trial matchers have offered only ranking of trials for patients with no true eligibility assessment. You can now, patients and doctors can now accurately determine whether a patient is in fact truly eligible, not as just, is this good, is this in the top 5 of is the doctor suggested trial in the top 5 of the rankings? No, it's, are you eligible or not? So as I said on this paper, future work will expand ACE evaluation to other cancers. We actually do support multiple myeloma and breast cancer. We've implemented error type classification, so we know like when we don't quite get what we want, like what was the kind of error that it was. The net result is we now finally have true precision eligibility matching. And as I mentioned here in the conclusions, the underlying exact system, of course, does power CancerBot, but it's available free to any patient support organization or cancer foundation. Thanks very much.